Kumran, thanks for coming down within a short notice. Mark putting arrow to Chung Ming and Chung Ming putting arrow to you. Arrow is a word I learned in
Singapore.
Singapore by Emmerich.
Ah, so the guy who's fresh out of the graduate school, right? He has a target board which has no arrows on it, and everyone keeps shooting because of fresh target board. No,
Oh, is it? Okay, so that's the welcome to Bangalore. This is the first time you're coming to Bangalore, right?
first time. And a long time. Over 30 years ago, I was here.
Oh,
I can't remember.
oh, nice. Tell us something, Kumaran. Like we all have done the orthopedic oncology. Right now, we are doing it, and you are into it. Tell me your journey from a young doctor's perspective. How in Singapore uh, did you? I mean, think of becoming an orthopedic oncosurgeon from beginning, which is quite unlikely, which we all happen to be as a serendipity, I would say.
Mm.
Or did it? Is there a structured program you went through? If you could tell the pathway, it'd be nice.
I think many of us been doing orthopedics would not have really understood about orthopedic oncology. It would have mostly been a chance meeting with a oncology surgeon during their residency or pre-residency, only post-residency, because the numbers are not that much, the exposure isn't there, and industry doesn't highlight orthopedic oncology as sexy as much as the hips and knees and sports surgeries. So many orthopedic wannabes end up being inspired to do something else, like function preserving more than life preserving. They end up maybe wanting the lifestyle. So very few of them want to do orthopedics for orthopedic oncology. So initially, I knew I wanted to do surgery in medical school itself, and along the way, I found that orthopedics was pretty straightforward in terms of if you do this in terms of physics, you balance the lever arms, you get that result. So it's in terms of you do this, you get A plus B equals to C, something like that. So I found it easy, and I got better grades in it. That's how interest started, and then you get inspired by your seniors who do orthopedics. So when I was waiting to join residency, there was a bit of a queue. There was this very senior surgeon, orthopedic oncologist, who used to part-time operate in my hospital. His name was Matthew Cheng, and he used to do surgeries which were mind-blowing, unlike any of the orthopedic surgeons I was attached to. And that creativity that he injected into all his cases got me inspired, because I realized that hips you only can do it that way, knees you can do it that way, sports you have to do it that way, spine there's only one approach at the back, mostly.
Yeah, exactly. One straight approach. Yeah.
But he used everything, the whole of orthopedics, and used every single element of orthopedics in the surgery that he did. So that really got me very inspired and interested. And he was a very altruistic fellow. He'll do surgeries for like 20 hours and give it free for the patient because they couldn't afford it. So I think that the heart was there, and I was inspired by him in terms of his heart as well as his skill and his creativity. So along the way, even before I got into orthopedic training, I wanted to be like him. And many of us are always inspired by someone. It's not just what you read on the books. You're inspired by a person, a living human being you have seen breathing and doing the same things as you, suffering in their own cheerful devotion they have for the passion that they have for the patients. So through him, I got inspired, and the inspiration stuck true. And it's sometimes very difficult to stick to this when all the rest of your colleagues are doing what is good for them, their families, their pockets, their rice bowl, and you are doing the path that's less chosen. But it's very fulfilling, I must say, because it gives you satisfaction beyond any lifestyle or any amount of money that comes into your salary, a paycheck every month, I would say. So that kept me going.
Yeah. That's a very, very deep thought. I mean, that's what I think. Even I got it, as I said. Profo inspired me, and then I happened to be in Rizzoli. Then I think once you feel, I think the world comes to play with you, and as you said, the feeling of connected to the patient, it's an amazing. And as you say, Matthew is the same person I remember when I was there. He's the one who transected the wire. Yes.
Hemicorporectomy. I know. A couple of them in Singapore, like that's all his work. In Southeast Asia, in fact. I don't understand why people fly down to Singapore to get half their body chopped off to fly back to their home countries without half a body.
Yeah. No. It takes really a guts to do all those
Yeah.
things. It's not like simple thing. So even in India, we have been, as we discussed before with Laura and Manfrini, the students or the doctors who or finished an MBBS, they always have a doubt what to choose, right? Does this speciality of our way of choosing, I mean, which happened on the way, can we extrapolate this learning to other specialities? For example, a doctor wants to do, say, an endocrinology or general medicine. Are we missing something in the teaching of in MBBS or in early life, so that if that kick, what we get it, the satisfaction kick at the end of the day, whether you like your pockets or whether you like your paychecks or whether that can we extrapolate it to the teachings of the MBBS? Do you have any thoughts on that to to make this, like, for example, I'll tell you nowadays what I'm doing is, how did even the sixth standard or a seventh standard kid, I intern them. I take them as interns. They have to just sit in my OPD. They have to attend a surgery. They have to, either if they're clinically fit and properly protocoled, they can come and see a surgery also. Even the new government, the government has told new education policy where a child should do a internship
Mm.
sixth standard onwards. Do you think exposing the children into a more altruistic methodology is important, and how do we come into action points if you know some things?
I think it's a very interesting question. So, whatever we have been learning in schools all the way till our childhood days, all the way till orthopedic MS, for example, it's all got to do with a learned process. It's a pattern recognition to make our decisions much more objective. But this whole process from the day we were born till the time we are here right now makes us unlearn whatever we think is the way, our own way of learning. It brings us all into this path that is being said is the right and only way to for the right answer. So all of us are judged based on exams and results, and all these tests are based on one standard marking. So you could then one question with one answer, one way of doing things, one way of thinking, one way. So we are having different people with different creativities, different strengths, different potentials, and all bunching them up into one path and making them into cookie cutters. So we're not allowing, not we, as in the whole world's education system. Maybe some countries have got it, starting to get it right. Making, not allowing each one to develop their own potential. So same thing for orthopedics, I feel. So we are taught this is the way to do a surgery. This is the what to look out for. This is what is this, and then anything away from it, we are very scared to do it. That's number one. Number two, we don't know whether it will work, so we choose the path which is more certain for us. But orthopedic oncology, you cannot do that. Like what we are talking to Prof. Manfrini, everything in orthopedic oncology, nearly everything is off-label. You have to be creative. There's no one solution for that problem. Every problem is so rare, and there's not, maybe it will be the first time someone in the world is experiencing that particular tumor at that particular location with that particular age group with that particular comorbids. So everyone is very, very unique. It's unlike like a normal hip or knee surgery where many patients may be similar, and then the way you do it, it's step by step. It's all protocolized. That's what's tested in our orthopedic training. So we have to unlearn what we have learned in orthopedic training for us to have open mind to take in those cases with more creative solutions to it. You cannot just do everything the same way and everything be a custom made 3D implant reconstruction, everything be navigation. So everyone is different and everyone has to be treated differently because every patient is different. So I think that kind of creativeness needs to be relearned in us, taught to us again from a younger age, and exposure is key. So what we see, what we are used to seeing as the way of doing things, someone else from a different background look at it from a completely different lens. Someone not from medicine, let's say you are a surgeon doing the same thing for 10 years. Someone from another field like engineering field or a business field or some other teaching field will look at the same problem and have another 10 solutions for it. And coming together as a different industry partners who are not people who are not blemished by the way of thinking will give us more wideness in the way we look at things. plus the way we look at things can also be used to influence year 6 or the 7th standard students who are coming in, and they can be inspired by different things that we do that we ourselves don't realize that we are doing. So recently I had one 10th standard student who was doing attachment under me. She wants to do medicine, and I was struggling in a case in theatre just 1 month ago. There was a I do trauma as well, so there was a terrible triad which had it all torn, and my fellow who was beside me was telling, let's just cast her and wait for the MCL to stiffen up. Then I was trying to fix up the MCL. Each time I put it in, the suture anchor will come off, and then she had no background about medicine, and my fellow was telling me to stop, give up, just cast her. And then I knew that it won't be a good outcome if you casted her because the elbow was unstable. So I was thinking, I was just trying again and again to find a good anchor point. Finally, we got a good anchor point, and then I put her on a hinge brace. Then at the end of the 1 week of attachment, the girl told me, it's like, I told her, sorry, I hadn't had much time to talk to you. I was extremely busy, as what you see, what you saw me doing. Then she said, you don't need to say anything. What you did was, I learned a lot from just what you did alone. Like that time when we went to theatre, you did not give up, even though the fellow was asking you to come off. And I didn't realize that. Until someone who's completely not medical was able to see that aspect of things, which I and him kind of overlooked, and anyone medical would have overlooked. So they teach us things, and we can teach them things, so that exposure for us is equally as important as exposure for them. And together we can inculcate creativeness, which is sorely lacking and sorely dying out in these days.
Yes, very true. No, on these lines only, actually, I got my children off the school about 7-8 years back. They did homeschooling for some time.
Wow.
No, I mean, I'll come to the story. So they did something called open schooling, where it's called self-learning. It's near my village. It's an Open Minds World School. So they were in a very nice environment where they had self-learning methodology, whether they can have a concept, they can learn either by studying books, either by digital gadgets, or either by mentoring, no teachers, or either by peer-to-peer learning. So these are the methodology they adopted. But now as the children are growing up, now the system is set for cookie cutter method, as you said. But the system even now wants marks, even now wants grades. Though these boys can do anything they call it a street smart or whatever you call it, they can come out with a solution if I give them certain time, certain tasks, certain gadgets, whatever it is. Now I have put them into the almost regular structuring at this end. Good, I experimented. I don't know the outcomes, which in the future no one will know those outcomes, what's going to happen. But as you told about this 10th grade student, this I thought I got to know, and 2 or 3 of these children are doing medical now. They have destined or they have targeted orthopedic oncology now. They want to become. 2 of my patients are my osteosarcoma patients. They are finishing MBBS. One person is joined orthopedics already. So they want to become an orthopedic oncosurgeon. Likewise, the Singapore education in class 5 onwards, is it going towards more of internship or physical involvement as they come to hospitals? They can go to industries, they can go to factories, they can go to a coffee shop to learn certain things, they can go to a farming. Is it encouraging? I mean, I don't know.
So it's getting more into that style where you have to have some experience, or they want you to do some internships before you sign on to that job. And I think that's a very good model to have as well. Because one thing that when people ask me, would you have done medicine if you had another choice? There was a long period of time where we were struggling, where everyone struggles in the first many years of training, wondering whether this is the right job, pay low, working hard, and no sleep, away from family, and just your whole life is 10-15 years of it. It's like that. And only after you get past all that, until you come to this stage, then you realize that these are your own patients, and you are treating them as what you imagined to be treating them when you were in 12th standard before you got started MBBS. That's finally after so many years, you see. So that one thing I will tell all the people who ask me whether I would chosen that, I will say no. I say yes, I would have still chosen it. But the only thing is that I wish I had more insight into what I was getting myself into. before I chose medicine. I don't think I would have chosen anything different,
Yeah.
but I would like to have known that all my weekends are going to be in the hospital. There's going to be birthdays and family dinners and things which are all going to be burnt. I'm going to tell my family, yes, I'll be there, but I won't be turning up. I wish I had known all these things in person before I had known. So these internships, yes, most definitely. So would be useful in
So insights and
knowing.
internships are very important.
I think it's
I
important.
think yes.
I
very
think
true.
so. But sometimes it's backfires. So in that 3 days or 5 days, intern comes and shadows you, for example. They'll get so inspired by the senior most surgeon doing all this cool stuff, all the sexy surgeries, that they forget that 10, 20 years of training that consists of majority of their life as the path, and they think that's where they're going to end up immediately after they join MBBS. So
I was coming to that point actually.
so that can backfire.
Yeah.
So if you really want someone to have insight, they need to be in it, breathe it, eat it, sleep it for at least like 6 months or so before they decide that's what they want to do.
Yeah.
But unfortunately, everyone is in the rat race, right? They feel that by spending 6 months of time investment, they will lose out with the rest of the peers who are already on board in MBBS and getting on with their lives.
Right.
But I think that 6 months or 1 year that you spend is a super important investment that you don't lose out in long term. Some things, medicine is not for everyone. It's too late. Some people realize it's too late for them when you're too much into it, and they grudgingly go past their whole life doing medicine and something they could have excelled in much better when if they were doing something outside of medicine. So it's better to realize that earlier and do something early, shift things earlier by spending the time investment in getting to know what you're going to do for the rest of your life.
Yeah, as you said, unlearning the learning means they have to learn it. As you said, that they see this fancy stuff doing, they suddenly think that I can do it without the learning happens. So the discipline structure has to happen. I think the Esther years of disciplining, learning, reading, studying has to happen to unlearn that and come to this discipline maybe.
Yeah.
So, but the thing which was missing earlier or even now is the practicality of it, which in orthopedic oncology or sarcoma care with the fellowship program I was just talking to Laura. So would it be great if pan world collaborates? Because ours is a very niche field, rare diseases, right? As there is no official university degree of orthopedic oncology in Italy, in India, in many of the most countries. But Singapore, taking an example, I was telling, for a hand surgeon, post MBBS, they can directly enter the hand surgery with certain things, right? They have a hand surgery degree directly after the MBBS, right?
So Finland, Singapore, and Switzerland are the only 3 countries that allow a hand residency directed.
Yeah.
Instead of orthopedics, then doing
Yes.
that. Yeah.
So I know it's a stuff for orthopedic oncology to follow because it's a whole body. But as a different bodies in the country, in the world, for example, if we make a body, say something, we give a degree of orthopedic oncology from these affiliated bodies, ISOLs, KEMSOS, Singapore Medical Council, some of these bodies affiliate. You go train. You don't give them a choice to train. You go train in these 2 institutions. This is what it's been supported, scholarship given by this. At the end, because most of the people post MS orthopedics in India, till MS orthopedics, you are on your parents' money. They were not paid even in the postgraduates in India. So you generally try not to do anything extra, travel around, learn something, and at the end, orthopedic oncology, who will take you? So this will be the end of it. So to avoid OOP surgeries, to have a high outcome in these children, the goal is very clear. These are all curable diseases. A child, we struggle 1 year to carry, but they put a bomb and they kill 1,000 children in a moment. As we discussed. So, do you think in the going forward, we all should, we know that we have to collaborate, we have to come out with a structure with these action points. Any thought on this?
So if there's an international syllabus or standard of training for fellowship trained oncologists, I think that's something that everyone would want to aspire towards and want to train towards, you see. So right now there's no international standard, let alone national standards, let alone institution standards for orthopedic oncology. I mean, some other bodies have started making a like hip and knee. There's certain requirements and things like that around the world. Maybe everyone needs to do a primary revision, learn how to deal with prosthetic joint infections, for example. But oncology is so varied that, firstly, it'll be good to have if a standard of care, so that, or a place to refer patients, barring boundaries, political international boundaries. That means you have Ewing's pediatric referral center in every part of the world has
Mm.
some. So the volumes are high. So the people there mostly do that, and they're good at doing that because workflows are very
Yes,
very very
yes,
done.
yes.
Or and everyone has to retrain to a minimum standard that's acceptable for everyone to be considered that you are able to do pediatric Ewing sarcoma, for example. The thing is that when, for example, ACGMEI in US has a minimum standard for residents to complete before they are accredited as specialists, then why are we allowing low volume sarcoma centers to function completely independently without even a national collaboration to make that a central sarcoma center? For example, UK has, they understand that NHS has only four bone sarcoma centers in the whole of UK, where it's all
Yeah.
60-80 million people all just go to this 4 units. So it's not just a standard of fellowship training as an individual, but it's a system that also needs revision. And world bodies like ISOLS or something can give recommendations for each country's sarcoma workflow to follow a certain referral pattern. So it's not just the individual that makes a difference, like not just a surgeon that makes a difference. It's a referral and a funneling of patients into the referral center, and for them to start working on patients that makes a huge outcome difference as well. Yeah.
Does Singapore has a sarcoma policy?
So not yet. So if we are a small country of only 6 million, and there's still 3 hospitals that does sarcoma care. So we are trying to get everyone to do as a single sarcoma unit.
But if there is a swelling, suspected swelling, if someone can operate in some private hospital in Singapore, they can get away with that.
Happens rarely nowadays because the education is there for all orthopedic specialists to take sarcomas as with a lot of caution. And if
Okay.
they're suspecting sarcomas, don't do oops lesion, just refer immediately. So in sarcoma practice, yes. In orthopedic practice, it's yes. But in general surgery practice, not so much education is there. So generally, we get most of the oops lesions from the general surgeons who refer them to us. Because all the sarcoma all the orthopedic trainees are
aware of
aware of it. Because there's only about less than 10 sarcoma surgeons in Singapore.
Yeah.
So all of us keep emphasizing that to the orthopedic guys.
Yeah,
The orthopedic guys, yeah, like, okay, I'll stay away. The general surgeons are the ones who don't deal with sarcomas as much, rather than retroperitoneal and stuff. But yeah, so they are the ones.
Yeah, good. So in this, you have trained in Singapore and you did your fellowship program abroad, right? In US,
UK,
with the Leges, I think, right?
Yes, correct. Yeah.
So UK. With the boys traveling across the world, we like, for example, I get the bones from Singapore, in Italy, not Singapore. So Singapore had a bone bank. I remember it is right opposite to hand department, if I remember correctly. So it is not there now.
It's not there. Yeah.
In India, I am always want to have a bone bank, a good bone bank. There are a lot of people who have bone bank, but like Italian way of, or there's one in Argentina. There's one in many parts of Europe where they fresh frozen allografts, non-treated, they no radiated. What's your need of a bone bank in this region? Forget Europe. Like in this region, like Singapore, Malaysia, Sri Lanka, India, Bangladesh, Pakistan, China, Thailand, Cambodia. This region don't have a good bone bank, collaborative bone network. So do you really think it is needed? Does it work? Do you need to make it like Americanize, capitalize the whole bone bank system?
I think in this part of the world, we need bone banks more than the European Western world, because over there, funding is a little bit easier. Patients can afford health insurance. Most patients are somehow covered by insurance in one way or another. Versus this part of the world, many patients still don't have insurance, and maybe the GDP is not as much as the Western world. If one of them in a lower to middle class income families get some of these devastating sarcomas, they can't afford any metal as a 3D custom made implants or any off the shelf mega prosthesis, endoprosthesis as a replacement, as a reconstruction option. Most of them rely on
Biologic.
allografts or recycled bone, their own bone recycle, you
Correct.
know. So I think having the option of a local bone bank which is cheap, easy to use, not commercialized like the US, for example, is very important here. If the reconstruction options of metal is not a viable option in terms of money, you know, and the resources is not as available. So it's a very cheap thing, you know, and it's harvested, kept altruistic, made cheap, and you know, when the standards are maintained, so the transmission is low and all this. I think it's more important here than any part of the world, actually.
What do you do if you need a bone in your country? If you need a good allograft, what do you do generally?
So most of ours comes from US.
Oh, even the humorous, like big ones, big bones.
We don't have a bone bank in Singapore, so
But
the big
do you get
ones.
the huge ones?
So we have to order in advance. So it might take for a while for the size to be matched for a donor over there.
Yeah, for example, for an humerus full bone, how much would it cost in Singapore?
It's expensive. US prices, so it's about US dollars about 2,000
Uh,
plus
there's plus the
3,000.
FedEx. That is good. That is equal.
Plus 3,000, 4,000 US
Yeah.
for.
The
Oh,
whole chain.
I'll just estimate
Approximate number. Yeah,
estimation.
just to for us to know.
Yeah.
Yeah. No, that's the.
And the matching might not be there, and by the time they get it ready and come over here,
The
plans
disease
might have
must.
changed.
Yeah.
Exactly, plans might have changed. You see,
Yeah.
so that quickness of it is not there.
The agility. Yes. Exactly.
Unless you have the ready-made ones, which are all the small bits and pieces like bone chips or some fibula strut or something like that, which comes in all shapes and sizes, or you crush it into and then pack it into the defect. It's not like a structural allograft. Yeah.
One last question or one ending thought. What I have, Singapore, we all know, we all respect, and it is like superb in every part of their culture, their way of growth. Where I also studied in NUH, the way they discipline me, whack me. But I mean, I thankful. I always tell that. With coming to the medical technology, like you are very good in navigation and you are doing it, all those methodology. As an orthopedic surgeon, do you think some orthopedic surgeon should venture into a med tech industry? It could be a startups, it could be industries joining. I mean, instead of some ex person who has no knowledge about medical, he starts a implant industry and grows into billions of millions of dollars. Versus why that state of mind is not getting or trickled into the medical people who aren't. We know the technology. We have every day. We breathe it. We beat it. We experience it. At the end, we go home happily. We did surgery. Nice. Let's go have a beer and sleep. So, but my suggestion is: do you feel some of the younger guys or somebody who wants to really get into medtech field, do they have to really forgo the surgeries or maybe do some surgeries, do some medical practice, get into the technology industry? Do you think it's going to change the outcomes, and do you think it's going to help the medical fraternity?
I think that's an excellent question. That's the holy grail of the future of orthopedic surgery, I feel, because we are so highly dependent on implants and products too in our cases, right? And like what you said, the person who is business minded will have thousands of business ideas, and come up with many products which are not translatable into putting into the patient or doing helpful for surgery. And the surgeon is too busy operating for him to say. He will come out like, this could be improved, but he never does anything about it. He always complains to the tech and will say this could be improved. Then the tech will write something down and then maybe just to show the surgeon that she's doing something, and then put it aside the next morning. And then after 1 month later, did you say something? I say yes, but they are working on it, but nothing gets done. You see?
Exactly.
So that person who needs the product or needs the innovation is the surgeon who has the problem in the operating theater, and he needs to be the parent of that idea and bring the baby to fruition and to grow the baby into an mature adult. So the other and the adult being the product who can be useful for all the orthopedic surgeons around. So I think, to answer your question, it has to be surgeon led, or it has to be a clinician led instead of a business model or money making model led from outsider to do this. But I think we can go somewhere in between if these
Mm.
people are flexible and they see this side of things and they're willing to
Collab.
go into really step down to the ground to really see what's needed and what are the problems associated with surgeons, and the surgeon is able to take himself away from the surgeries and look at it in a big picture and how is it like business model, how is it going to expand your ideas. So that's the bridge, that's the finest line and the weakest point of the whole bridge. You have very strong surgeons, very strong business people, and the bridge in between to make this idea come to the surgeon and the surgeon's idea go to commercialization. That bridge is missing, very
Yeah.
very thin. So it's not, you don't need to completely stop
Yeah, yeah,
operating
yeah,
to do that,
yeah,
but you need to follow your passion through,
yeah.
and you need to, at one point you'll decide whether operating is your passion, the biggest passion, or developing this idea is the biggest passion. Money might not be, is not the your calling, but to see that thought of your thought develop into a product and to see that whole process through, that might be more satisfying to you as a surgeon than operating. Then you'll give up a little bit, something has to give, right?
Yeah.
You cannot stop operating because then you lose touch with that, and then that product will being developed into something that's not useful again.
Correct.
Is it? Japanese orthopedic surgeon, he gave up. He was lousy at operating. He knew what was more important. He ended up winning the Nobel Prize in just 10 years ago. He's a no,
Yes, I
yeah,
know.
yeah.
I
So
don't know
the
that.
orthopedic surgeons can do a lot of things as well.
Yeah, exactly. Who knows? I can become
In Singapore, a couple of orthopedic surgeons are ministers because the way they talk, the way they think is a little bit broader than many of the other physicians out there. I
Is it
feel.
Andre Chia?
No, Audrey is going to be one, but not yet. Not yet. Yeah. Yeah. So
Anyway.
we have a lot of potential. We shouldn't just bury our potential thinking that that's the only thing that we are capable of doing. Because if we step away from what we engulf ourselves in, day out, we will be able to see the bigger picture, and we'll realize where our potential is most likely to bloom or to give back the best to society.
Yeah, as you said, recently I was listening to Elon Musk with our Nikhil Kamat's podcast. So he said a nice word. In next 20 years, he said almost everybody will have a like UHI. I was like, what is this new word? Ultra high income. He said, how is it possible? It's a very nice calculation he gave. So because of AI and robotics, it is going to be deflation.
Mm.
How AI and robotics can deflate? Because production cost becomes lower, demand becomes lower. Now its demand is high, production is low. So deflates. So everybody will not work for money is what he's telling me in the future. Probably the creative or the people who are want to bring a solution to a society are a social entrepreneur. I mean, you cannot just give everything being without doing any business, without doing any work. You cannot live life, right? It has to be a balance. I think that is where, as we think, that's why we initially, when I started 3D printing, I saw 5 3D printing companies closing in front of me. They are engineers, and I'm a doctor away. We're collaborating, but businessman is not there. See, they closed. I don't have a solution. So now I bought the engineers myself. I have engineering team, I have seen, so they do it everything. But I'm still a doctor. There's no business. That's why I'm still not able to make profit out of it. I think as I'm learning with this, I think probably some businessman should come there and inject that push, then should go up. Otherwise, it'll stop there one fine day. I finish my work, you finish your work, and you wrap up the company and go. That should not happen. The whole work of Professor Manfrini, imagine if it is not documented. That's what I keep telling you. It has to get documented for the full generations to come up, whatever it is. So this is one part of documentation what we're doing with this podcast. So any final thoughts on for the parents with sarcoma? If you could give a message, because they are the ones who run through a lot of problems, and it's a long way, as you said, 1 year of whole thing. Any final message you want to before we wrap up the session?
I think it's not for the parents who have kids going through sarcoma treatment. It's really not easy at all, and it shouldn't be like, why my child, why me? No, it's happened. It's happened. All happens for a reason, or if you don't believe in a reason, it's happened. This is what you are presented with, And how you go on from there is how the outcome of your child will be. If you are weak and you cry about it and you are worried about it, your child will know that this is a disease. Your child does not know that this is a debilitating disease until you make them feel that they are handicapped or they are debilitated because of the disease. So a lot of your child's confidence and their outlook in life is determined by how you behave and how you treat your children, even while they are going through the treatment. The treatment is physical treatment is for them, but the parents play a huge role in the long-term outlook and long-term prognosis of the patients mentally and physically and emotionally, and how they project them to be functioning people in the future. They will only be labeled disabled if the parents bring them up to feel disabled, or the parents overprotect them and over shelter them because of this disease that they have. If they will give the right encouragement at the right time, not too much of pity, make them go into and rough it out just like any other kids, the kid will feel that their disability is never disability. They'll feel like they are just like any other kid who had gone through the treatment, who has a one shorter leg, who had one amputated leg. That's all they'll feel. So that's very important for parents to know. It's difficult, but remember that you are finally responsible for the outcome of the mental outcome of your children, how they have confidence in themselves in the future. So that's what I would like to say.
Yeah. I think before this, I was just telling all of our kids who have finished treatment 5 years down the line, 10 years down the line, they are more mature than any of that same age matched children.
Absolutely.
That's
Absolutely. Because they've gone through that much more than any other kid who has gone through, right? So
for sure, I learn a lot of things from what I treated the patients, the way they speak to me, the way they come back as a consultation, the way the maturity is. It's amazing. So you are actually, if this is a process of sarcoma care or treatment or whatever is the chemotherapy, you are building a new child, according to me, a newly mature, fantastic citizen to the world. That's what I look at it.
Absolutely. I completely agree with you. And what they have gone through, they have learned so much from the experience,
Yeah.
And I really hope that sarcoma treatment in the future allow all these children to survive to a ripe old age where they are like 10 times more productive and mature and give back to society a lot more with the experience they learned during that very formative years of their lives.
Exactly. Thank you, Kamran. Thank you for this nice talk. It is nice, and in a short notice, you came all the way. And
my pleasure, my pleasure, my honor to be here. Thanks for having
keep coming.
me.
Thank you.
Thank you. No problem.
Thanks.